So this lecture is going to be on cardiovascular disease. Now that is a generic term for disorders of the heart and the blood vessels. This is going to be the leading cause of death and disability in the United States. We're going to be really focusing in on coronary artery disease. So coronary artery disease is a narrowing of the small blood vessels that supply blood and oxygen to the heart. CHD is also called coronary artery disease. CHD is caused by impaired blood flow to the myocardium and is usually related to atherosclerosis, which is an occlusion of the coronary arteries by fibrous and fatty plaque. These patients can be asymptomatic, and they can also have angina, acute coronary syndrome, myocardial infarction or MI, also called a heart attack, dysrhythmias, heart failure, and even sudden death. And you can see here on this slide a comparison between the normal artery, which is pretty clear, and then the build-up of the plaque. So you have two main coronary arteries, the right and the left arteries, which supply blood, oxygen, and nutrients to the myocardium. The left main coronary artery divides to form the anterior descending and the circumflex arteries. Anterior descending artery supplies the anterior interventricular septum and the left ventricle. This includes the apex of the heart. The circumflex branch supplies the lateral wall and the left ventricle. The right coronary artery supplies the right ventricle and forms the posterior descending artery. The posterior descending artery supplies the posterior portion of the heart. And you can see a really good diagram here of the different arteries. So going back to atherosclerosis, this is a progressive disease characterized by atheroma or plaque formation. It affects the intimal and medial layers of the large and mid-sized arteries. This can be caused by unknown precipitating factors that cause lipoproteins and fibrous tissue to accumulate in the artery wall. The precise mechanisms are unknown, but abnormal lipid metabolism and injury to the inflammation of the endothelial cell lining of the artery appears to be key in development. These plaques can also burst or rupture, and it triggers a thrombus. Although atherosclerosis is often considered a heart problem, it can affect the arteries anywhere in the body. Atherosclerosis is preventable and a treatable condition as well. Oh, you go this way. So as you can see, this gradually occludes the vessel lumen and impairs the ability to dilate in response to increased oxygen demands. Fibrous lesions often develop at the arterial bifurcations or curves or in the areas of narrowing that can produce stenosis or total occlusion. These can rupture, ulcerate, or stimulate thrombus. The lumen becomes rapidly occluded by thrombus or may embolize to occlude a distal vessel. The heart then is not getting enough blood and oxygen supply to meet its needs. And you can see here the difference between an open vessel and as it starts to occlude. And this is where you're going to get your chest pain. So this is an ongoing inflammatory process. It starts with damage to the endothelium due to factors such as smoking, hypertension, hyperlipidemia, infections, or inflammation. Many of these risk factors can be controlled with lifestyle modifications. The highest incidence you're going to find is going to be in Caucasian men greater than 45 years of age. And with women, the onset is about 10 years later. So we have hyperlipidemia, excessive pressures due to hypertension, toxins such as cigarette smoke, infections, and inflammation. These can promote arterial endothelium injury or damage. This promotes platelet adhesion and aggregation, and that attracts the leukocytes to the area. So there's a distinction between non-modifiable risk factors and modifiable ones. So here are some examples of the of different types of risk factors. So for non-modifiable, you have age greater than 65, gender, we already talked about males being at higher risk, genetics, that would be your family history, and with males, it's a first degree relative that's younger than 55. So that means that if you're a male and you've had a heart attack at less than 55 years of age, then your children are going to be at higher risk. And the women that are at higher risk are the ones that go into premature menopause. So your modifiable risk factors are going to be your smoking. Hypertension, to some extent, is modifiable with diet and exercise and adherence to medication. The same thing would be with your diabetes and your hyperlipidemia. So with your plaque formation, it tends to be eccentric, which is located in a specific asymmetric region of the vessel wall, or concentric, which is involving the entire wall or the circumflex of the wall. The manifestations of these do not appear until about 75% of the arterial lumen is occluded. And you can see there's a good portion of this one that is occluded. Additionally, this tends to occur where the arteries bifurcate or branch. It is more likely to occur in the coronary arteries, especially the left anterior descending, the renal arteries, and the bifurcation of the carotids. This can also happen in the branching of the peripheral arteries. Atherosclerosis also weakens the artery wall, which increases the chances of aneurysm. So there's different classifications of cholesterol medication, which we're going to be going over. First, we're going to talk about statins. This is a medication to lower total serum cholesterol and LDL levels while raising HDL levels. That's important to maintain coronary heart disease. They are used in conjunction with diet modifications and other lifestyle changes. These drugs act directly by lowering the LDL levels. We want those levels less than 130, but ideally less than 100. Four major classifications of cholesterol-lowering drugs are going to be your statins, your bile acid sequestrants, the statins are going to be your first-line drugs, but your bile acid sequestrants and the other ones can be used in combination therapy and often are required with statins. You won't always see this, but a lot of times you will. A lot of these are going to be pretty easy to remember because they're going to end in statin. They're going to be like your lovastatin, pravastatin, atorvastatin. So a lot of them are going to have those names that are pretty easy to remember. This is your first line treatment again. And your nursing considerations with these are going to be increased liver enzymes and then myopathy. So when you're doing your patient education on these medications, make sure that you advise your patients to report any muscle pain or weakness and brown urine. Liver enzymes are monitored because they can increase those. Be aware that if they are on a statin and they're taking DIG, you need to monitor for digoxin toxicity. And some of the signs of symptoms are anorexia, nausea, vomiting, altered level of consciousness, course, and cardiac dysrhythmias. Your bile acid sequestrants, those are going to be used in conjunction with statins, and these are used with women who are trying to get pregnant or can be used with that. And examples are going to be your Questrin and your Welchol. More often than not, I see the Questrin being used. So for nursing consideration, the sequestrants can cause a lot of constipation, so you want to educate your patient on drinking lots of fluids to help prevent that. And you do not want to take these with other medications that will interfere with absorption. So you're really going to separate those from your other meds. You're going to mix it with a powder or juice and about 4 to 6 ounces of that. And this is one of those medications that gets pretty chunky if you don't mix it well. The nicotinic acid is also used in conjunction with statins, and this decreases triglycerides and lowers the total cholesterol. For nursing considerations, you want to give this with food to decrease GI effects, possibly a cold beverage, and you want to monitor their glucose and uric acid levels as well as their liver function. That being said, you want to use cautiously with anybody with diabetes, liver failure, or patients with a history of gout. Some other issues you might see with nicotinic acid is the patients could get a flushing of the face and the ears about 2 hours after the dose. This can subside pretty quickly, but alcohol can increase this effect. You also want to make sure that you're monitoring for any orthostatic changes. And then finally, your fibrates. These also lower triglycerides, but only slightly affect the LDL. So your nursing considerations are going to be to take with meals to decrease your GI effects. And this one can take about 2 months to reach a therapeutic effect. And this is one of the medications that you cannot use if you're pregnant or trying to get pregnant. And of course, lastly, I put a page number on here for all your nursing considerations. But these patients do need quite a bit of education on lifestyle modification. Just so keep that in mind moving forward when you're talking with your patients. A lot of them are more geared to take a pill than they are to change something in their diet or even exercise. Okay, so MI. Myocardial infarction is going to be a major complication of atherosclerosis. Coronary heart disease is usually due to atherosclerosis and occlusion of the coronary arteries by our fibrous fatty plaque. This leads to decreased oxygen supply. It's really inadequate to meet the metabolic demands of the body. So you're going to have ischemia, and it's going to be an alteration of O2, and it's inadequate to meet the metabolic needs, of course, of the heart and the body. And this can happen in one or more blood vessels. And it can be a partial occlusion or a total occlusion of plaque. So if you think back to those earlier pictures, or this picture we see here, this one has a pretty decent amount of blood flow, and it just kind of progressively gets smaller and smaller to the point where very little blood is going through. So looking at our normal anatomy over here, where we have a healthy heart with a lot of blood flow, and then we have some impairments here, this is where you're starting to get your damage. That's your MI right there. So there's an occlusion like this going on in this artery, and it's causing that part of the heart to be damaged. So that's where your MI is occurring. So this is where your patients are going to start developing chest pain or angina. This is resulting from reduced coronary blood flow. Causes a temporary imbalance between myocardial blood supply and demand. This can be from the narrowing of the blood vessels, like what we talked about in atherosclerosis, or hypermetabolic conditions like thyroid toxicosis and stimulants, hyperthyroidism, or even emotional stress. So this increases myocardial oxygen demand. Keep in mind that there are other health conditions that are going to affect your oxygen supply. An example of this would be anemia or ventricular hypertrophy. And it's your decrease in oxygen to the heart that causes your chest pain. So there are going to be two types of angina, and we're going to talk about both of them. You're going to have your stable and your unstable. So with angina, the discomfort is described as tight, squeezing, heavy pressure, constricting sensation. Characteristically, it's located beneath the sternum, but it may radiate to the jaw, neck, shoulder, and arm. And here are some different examples of where different patients are going to experience chest pain. Just keep in mind that women typically don't present the same way with their pain as men do. So just because they're not having that crushing chest pain does not mean that they're not having an MI. And of course, they're going to have other symptoms such as fatigue, indigestion, nausea, vomiting, upper back pain, and of course, diaphoresis. This is where your cold spa is going to become very important. You want to make sure you do a thorough pain assessment to determine exactly what is causing your patient's pain. So stable angina, this is going to be your most common one. This is the type of chest discomfort caused by poor blood flow through the blood vessels of the heart. And this is supplying the myocardium. So this is caused by increased activity that puts more demand on the heart, requiring more oxygen, but the arteries cannot dilate enough to give the heart more oxygen. This can be caused by any condition that increases the workload of the heart. So exposure to cold, eating a heavy meal, strong emotion, stress, all of these can precipitate angina. A lot of times in the wintertime, you'll see those gentlemen that are outside shoveling snow, and that's when they start to get their chest pain. This usually lasts for about 5 to 10 minutes. These symptoms are often predictable. That means that the same amount of exercise or activity may cause the angina to occur. It should improve or go away when they stop or slow down their exercise. So with our example of the gentleman shoveling the snow, his chest pain should stop if he stops shoveling the snow. So it should be relieved also by nitroglycerin. Other sensations they may have are going to be your indigestion, dizziness or lightheadedness, nausea, vomiting, and your diaphoresis. They could also have palpitations, shortness of breath, and unexpected tiredness after activity. And that effect is more common in women. So the classic sequence for this would be your pain, that's your activity, rest, and then you have relief or recovery from the pain. These are going to be your patients that also have some relief with nitroglycerin. So then we have our unstable angina or acute coronary syndrome. Unstable angina is a condition in which your heart doesn't have enough blood flow and oxygen. This can lead to a heart attack. This can occur at rest and may not go away with medication. Your patients are going to complain about feeling different. It's more severe and comes on more often or occurs with less activity or even while resting. It lasts longer than 15 to 20 minutes. So they could be occurring without a cause. So they could be waking up from sleep or sitting quietly, and it doesn't respond well to medication like nitroglycerin. Often occurs with a drop in blood pressure or shortness of breath, so just be aware of that. Your symptoms of stable or unstable angina can include chest pain that you might also feel in the shoulder, arm, jaw, neck, or back, discomfort that feels like tightness, squeezing, crushing, burning, choking, or aching. A lot of times these patients will say that it feels like something is sitting on their chest, and the discomfort that occurs at rest and does not go away easily or when you take your medication. Shortness of breath, of course, always, and these are going to be profusely diaphoretic, so it's like a lot of flop sweat. Not always, but a lot of times they do. So I put this picture in here again just to remind you of why they would be having this chest pain. And you can see here how decreased this blood flow is. So somebody with a marginal amount of occlusion, they're going to be your ones probably with your stable angina that goes away after rest. So they rest, everything returns to normal, the heart gets blood flow again. The ones with a more severe occlusion, those are going to be your unstable angina that leads to an MI. So nitroglycerin. These are available with different methods. They come in the transdermal patches, sublingual spray, tablets, IV, and a paste. So when we are educating our patients on chest pain, the one that they're most likely going to be having ordered for them is going to be the sublingual treatment. So that's going to be sublingual spray or the sublingual tablets. The ones with long-term cardiac history are going to get more of the paste or the transdermal patches. So the nitrates are going to dilate both arterial and venous vessels depending on the dose. This is going to cause vasodilation, which increases blood flow and oxygen supply. So you want to make sure your patients that are taking patches take those off at night, and you want to do that to prevent tolerance. So they're not going to be wearing them 24 hours a day. These patches are not for acute attacks. For acute attacks, the patients are going to be using the sublingual, so the tablets and the spray. So what we do when we educate patients on these, when we send them home with their nitro, is we tell them to take them with chest pain. So they're going to take one tablet, put it under their tongue, and they're going to sit down, rest, and wait 5 minutes. So after 5 minutes, if they're still having chest pain, they're going to take a second dose. They can do this up to 3 times. So one tablet, 5 minutes, second tablet, 5 minutes, third tablet. If after 5 minutes after that third tablet, if they're still having chest pain, we educate them to call 911. We do not want them driving themselves. We also want to stress to these patients the importance of sitting down or laying down after taking nitro because of the decreased cardiac workload and to prevent orthostatic hypotension. We do not want them passing out. For patient teaching, we want to educate them on the importance of keeping this in the original bottle. And you can see here that it's a colored bottle to help maintain the integrity of that medication. Use caution, of course, when standing because of orthostasis. Rotate patches, that's going to be with any patch. And then monitor for the expiration date. And there are signs and symptoms, which you've probably covered in pharmacology class on how to determine if nitro is expired. So if your patient is using their nitroglycerin and they don't get a tingling sensation of their tongue or they don't get a headache, it doesn't necessarily mean that their nitro is not working. It could just be that it's not as potent as it was. And a lot of times it will decrease potency if they take it out of that original container. So one of the acronyms they use in the hospital to treat chest pain is MONA. So that stands for morphine, oxygen, nitro, and aspirin. And it just kind of helps you to remember how you're going to be going about treating this patient. So the morphine obviously is to help decrease the chest pain, and it kind of opens up the arteries as well. These people have decreased oxygenation to the myocardium, so that kind of helps with that. And then the nitro, that dilates everything, so it's a vasodilator to help open up blood flow. And the aspirin, of course, is the antiplatelet. And they want to chew that for faster absorption. And the whole point of that aspirin is to decrease clot formation. There's going to be other things they'll probably order in the future, like Plavix, but in the beginning, it's going to be your MONA. And that's morphine, oxygen, nitrates, and aspirin. So here we have our non-modifiable risk factors. These are the things that can't be changed. So over 50% of MI victims are going to be 65 years of age or older. The genetic factors and gender, of course, men are affected at an earlier age than women, and then a family history of heart disease in males. So this is going to be a first-degree relative younger than 55, or a first-degree female also younger than 65, because remember, men are affected earlier than women with heart disease. So here are your modifiable risk factors. So these are the things that people can change that include lifestyle factors and pathological conditions that predispose the patient to developing coronary heart disease. So hypertension is going to be a big one. That's a consistent reading greater than 140 systolic or 90 diastolic. The hypertension really damages the cells of the arteries, and this can stimulate atherosclerotic plaque. So diabetes, this is going to be associated with higher lipid levels. Smoking, of course, and this includes secondhand smoke, and this damages the endothelium, promoting cholesterol deposits. The atherogenic diet, this is going to be your Western diet, high in cholesterol, so think your steaks, your meats, your bacon. Sorry, everybody loves bacon, but it's not good for the heart. And then the risk factors specific to women include oral contraceptive use, hormone replacement therapy. Those are going to be two big ones. So these risk factors can be controlled through medications, weight control, diet, exercise, and behavioral lifestyle changes to decrease stress and anxiety. And these are all going to be excellent points for patient education to promote health. So for diagnostics on these patients, we're going to be taking a serum cholesterol level that includes triglycerides, HDL, LDL, VLDL. We know that elevated levels increase the risk of atherosclerosis. We're also going to be checking a C-reactive protein because this is associated with the inflammatory process. And remember that atherosclerosis creates an inflammatory process. So ABI, this is going to indicate the presence of peripheral artery disease and a significant risk for CHD. Then we have our exercise ECG testing, and this is considered positive when myocardial ischemia is detected, and that's going to be your depression of the ST segment on the EKG. And the patient will also typically present with chest pain during this exam if it's positive. Then we have the electron beam computerized tomography. This creates a three-dimensional image of the heart and the coronary arteries that can reveal any type of calcification. And then when we do perfusion testing, that's to evaluate blood flow and perfusion at rest and during stress testing. And those can be done by exercise or by medications like persantine. Some other tests can include radionuclide testing, and that's a non-invasive way of evaluating myocardial perfusion. And then the coronary angiography, so that's when they're going in through the groin and they're using a fluoroscope by a catheter to determine how well the arteries are opened. During those procedures, they can often do like an angioplasty too if there is an occlusion, and more often than not, when you have those mild heart attacks, you'll see that they're able to do that. Now, sometimes those patients aren't a candidate and they end up having to have open heart surgery anyway, but just realize that that is a possibility. They might be treated in a very non-invasive manner, or rather minimally invasive in this point. And then there's also the example of echocardiograms, so those can evaluate your cardiac structures and your function as well. So this is just an example of a diagram that will help you to remember what we're looking for as far as manifestations of chest pain. You're going to have your cold spots. You're going to be evaluating their pain. You're going to be looking for signs of shortness of breath or dyspnea, syncope because of a decreased blood pressure, nausea, vomiting, extreme weakness, diaphoresis, that's that flop sweat we talked about. And this is just a nice little slide that describes the 3 areas of damage after an MI. And then we've got one on MONA as well. So again, morphine, oxygen, nitroglycerin, and aspirin. The aspirin looks like it's cut off, but it is there. So morphine, oxygen, nitro, and aspirin. So for nursing care, we want to go with prevention. That's really the key. Drug therapy is used in conjunction with diet and lifestyle change. Diet and exercise programs that emphasize physical conditioning and a low-fat diet rich in antioxidants have been shown to really be effective in managing coronary heart disease. The goal is to decrease their LDL less than 130. The HDL can be increased by quitting smoking. That can help with that, and it can actually impact it by as much as 10%. Weight loss if they're overweight, losing even a few pounds can help improve the HDL. And then for every 6 pounds or 2.7 kilos that a patient loses, their HDL may increase by 1, so that's pretty significant. And physical activity within 2 months of starting frequent aerobic exercise can increase HDL cholesterol by about 5%, and otherwise sedentary individuals. So your best bet for increasing HDL cholesterol is to exercise briefly for about 30 minutes, 5 times a week. And of course, education on medication is always important, to adhere to their regimen and educate them on how to use their medications and look for side effects. So health promotion, we already talked about increasing daily exercising and quitting smoking, healthy eating, weight loss, and one thing I didn't mention before was lowering their stress level. I think I kind of glossed over that, but that's also very important. And then early screening. And then here's some examples of your nursing diagnosis for this. And then I just wanted to give you a reminder to make sure that you review the other PowerPoints on D2L, because those are going to be included in the exam as well. So PVD would be the other one, and there is a voiceover available on that one. And then for the following week, then the next one is already loaded on D2L as well. So if you have any questions, just make sure that you email me or post something on the discussion board if you think it would be helpful for the whole class.